I'll briefly introduce here Professor Imrana Quadeer. She was professor in JNU Center of Social Medicine and Community Health. After her retirement, she joined Council for Social Development as distinguished professor. During her tenure as a teacher I think she taught in JNU for over 35 years, several subjects. All of them are with critical and interdisciplinary perspectives which strengthen her students and younger generations' ability to think in critical terms. And she has also worked with the planning board, and she was member of advisory committee for the RCH, for the NRHM, and she worked with planning board and Ministry of Health. All her contributions, research, teaching, and all her contributions are much critical for the public health development in the country. I very warmly welcome to you, ma'am, and thank you so much for joining us. Over to you. And the session, one second, the session is, since she's the only speaker, we can have, as we want it, as much as possible, she can speak and we can listen and we can discuss things.
No.
So, thank you.
It's really nice to be a part of this discussion. As Tracy has said, it's the timing is really sad and unfortunate, and actually I don't know, I wish we could all be in some way giving a lending hand to the people who are suffering. I don't know what this country is doing to itself, that this metropolitan city, which calls itself one of the biggest cities of the world, 5 people have died since yesterday. Within the last 4 days, because of the flooding and clogging of drainage systems, and it's just shocking that a city with broad roads, colorful lights, and the Rashtrapati Bhavan and the Prime Minister's house has people dying because there are drains in which they disappear, because the students die because they are in underground libraries and they can't get out because of the callousness of the people involved. So I think in a way what we are going to discuss today is also very relevant, because it's time we all started thinking what's happening around us. Before I go to the subject, I just want to point out 2 things. One is that maybe some of you might have read a bit that I have written on private sector and corporate institutions, and I've always been very critical. So people take it that I'm against private sector. And I want to say that, we need to understand even the private sector. One, that it is not a homogeneous entity, and 2, that private sector also has changed over time. There was the time when you had people like D.C. Roy, you had Dr. Kutnis, you had Dr. Heme Ansari, you had Dr. Jagopal Mukherjee. I can go on counting, but we don't have time. These were private practitioners who fully involved with the national movement. They fully involved with the possibility of building a people-oriented public healthcare system in this country, and who provided free care to the patients. So that was also private practitioners and private sectors. It was a small sector, it was a weak sector. After independence, when the country kind of stabilized, we went into institutional building, and there were lots of very eminent doctors who involved themselves with building institutions, medical colleges, research institutions. And so professionalism grew in the country. Many of them were private practitioners also. But as time moved on, our professionalism has taken us away from the ground base, from the people. And we just think of cure and treatment and medicines and technology. But people are kind of receding and are being replaced by profit making. And that is also private practice. But that's not enough. When the profit making becomes so much that you forget about the basic ethic of practice, and you forget about the essential oath that we talk of, then there's a problem. And therefore, then medical care becomes commoditized, when commercialization begins, and when financialization comes into being. That's when there is a huge problem. And I think that's the problem we are facing. So it's not a question of just not liking the private sector. I think there are lots of excellent doctors in the private sector, a lot of very concerned doctors in the private sector, who are also working with us and trying to do what they can. The important thing is to understand the system. And that's my second point, that, what do we mean by a system? It's these days it's become very easy to, just adopt terms without really understanding what I am meaning by it. So let me just say that for me, a system is a complexity of elements in relation with each other. These relationships may change depending upon the character and the composition of the elements, and that these elements put together are more than just the summation of each other. They become one, and that oneness is directed towards an objective. And if you go back to the way people have understood public health, whether it was Winslow 100 years back, or it was the Alma Ata definition, the definition was that a public health system or even a medical care system works for the well-being of the total population, that it is ethical, it works towards equality, justice, it works to provide need-based services and services which are acceptable to people, which they can afford. Now, that objective, the important thing is that can systems remain constant? And we have seen historically that even the objective of the system can change depending upon how those elements are moving, how the relationships are changing. So please remember these two things about the changing nature of the private sector and the system. And public health system, I know that we all talk of social determinants. We begin with clinical medical care at the core of the system. And when we talk of medical care system around it and healthcare system around it, where you may include a bit of the social dimensions like nutrition, like water supply, like electricity, like roads, like education. But you can go beyond that within the actual social domain of society, which is the social structure. Because this is the domain from where the patients are coming, from where the providers are coming, from where the people in government are coming. And in this broader concept, what do we see? If we are talking of, an ethical public health system which cares for the all, then in a poor country, somebody has to provide the finances, somebody has to provide the material. And who's that somebody? And the understanding was that it is the single pay state which is going to support the public health system. But as the system has changed, it's not just one provider. Many actors have entered, and what we have is a system in which we are talking of many models. I will come to that a little later. But first of all, let me just touch upon the fact how and why the public health system and the relationship between the providers and the recipients, whether it is private or through the state, maybe national health insurance, maybe financed by the state itself, how it changed over time. And I think it's very important to understand that this has to do with the global context. I know we ought to be talking of the local, but I want to begin with the global, not because that is where most money comes from. It's not that. But by giving a little money, they completely distort it. And that is why I want to begin from there. Because most of us are so involved in looking at the public health care system or the medical care system that we don't look at the larger domains of the social structure, the global policy, and the role of the governments. So I begin from 1940s to 70s. That is the period of 1945, you can say, the Second World War, the European reconstruction, the emergence of the World Bank and other international financing institutions who were actually involved in the building of Europe. And there was a liberal ethos. So they were trying to evolve their markets, their economy, their society. And in this liberal mood, they were also trying to interact with the poorer countries. At that time, we called ourselves the third world countries. there is a politics to terminology, and I don't want to go into it, but you should know that the change in this term is a very political act. Now, from that era, what happened? When the global market grew a lot, it became very competitive. And within the Western countries themselves, competition arose. And with that competition, obviously, the MNCs and the TNCs of the UN, uh, the financial institutions there, they were very powerful. And this competition led to offering of a very different policy. It's no more liberal like before. They wanted to cut on their welfare. They wanted to focus on productivity. They wanted to focus on profits. And they wanted to treat the world around them differently. So they did three things. For their own countries, they said austerity is the best solution. So there were problems, but they saved their welfare systems and they protected their agriculture. But when it came to the socialist countries, they said they need a shock therapy. So they stopped all policies and interactions which were positive. And you know that how the Russian economy and healthcare system almost fell apart at that point in history. The third world was offered something called SAP, structural adjustment policies. The structural adjustment policies were a set of policies which said, open your markets. Now, we'll look at it later. Within this, what happened? That to the third world, they started offering trade. They become a part of the market. We'll give you concessions. So WTO happened. GATT came in. General GATT trade and in which they had the intellectual property right and all the rules that were evolved for international trade. Now, this is something very important and interesting because different countries reacted differently to it. And that was according to their context. And what was our context? See, in post-independent era, there was a liberal relationship with Nehru standing up and saying that, yes, aid and help is acceptable, but at our own conditions and retaining our dignity. Then, at that point of time, in India, the focus was to have economic growth. So they did land reforms, they build heavy infrastructure in industry, they set up public distribution systems. Now, this is interesting because just before independence, we had the Bhore Committee report. The Bhore Committee report I'm sure all of you must have read it, is very clear about the relationship between poverty and health. And it's very clear that the two go together. And it imagines that while it is planning for the health sector, uh, the economy will grow on its own trajectory. And you know that at that point, uh, there were different plans offered. There was a Gandhian plan, there was a people's plan from trade unions, there was an industrialist plan from the industrialists, and different strategies to achieve our goals. The problem with Bhure committee as it was, although it's a very well done report, first report which has taken such an exercise in this country, collected massive amount of data. It visualized planning for poverty and health as very linked, but it never set up its goals to check whether the two are acting together and whether the changes in health are correlated with economic growth. So the two in practice were not linked, the two in the mind were linked. Interestingly enough, if you look at the second plan was a very interesting plan. It was basically worked upon by Mahalanobis and Nehru. And Mahalanobis, for the first time, used the systems approach, the operations research approach. And he said, I'm not interested in theoretical debates. I want to tackle poverty in this country. I want to use science, rationality, and reason to understand the system. And my planning for economic growth would be such that it will take into account all other sectors that contribute to economic growth. And in that, health was very critical. So he talked a lot about how to rationalize health system, how to collect data, how to plan and monitor and evaluate, and how to develop feedback systems. I mean, it's a pleasure reading the second plan, even if it never was put into practice. I think we should all read it for future use. So that was the second plan, that is the end of the 50s. And then, you know, the progressive steps taken, 50s and 60s, there were also problems. And the problems were that I mean, this is it's a country of vast differences. And we came together to fight for independence. But when the fruits of the independence didn't reach, different classes started getting impatient. So the poor was impatient, but he was not getting as much as he had hoped for. The rich were too much in a hurry. They were looking towards the offers that were being made by the international market, and they wanted to change the trajectory of development. Now, it's a subject by itself, and I'm not going to go into the details of it, but what I'm trying to point out that despite having a perfect model of economic planning that integrates health into it, despite beginning with progressive methods, that strategy did not go through. And it did not go through because of social reasons, because there were differences of opinion, because there was labor unrest, there was oil crisis, 1975 to prevent all that emergency happened. And following all this turmoil, ultimately by the end of 80s, we accepted, not end of 80s, actually the changes started mid 80s itself, although formally SAP and structural reforms were accepted in 1990.
Oh, ma'am, you are not audible. Is there a network issue? It's not audible, ma'am. It's not audible. I think there is a network issue.
No, she is gone on mute by mistake.
Okay, that's.
Tell her.
No, but I can't see it's muted, Anyway. Ma'am, can you unmute it or and now it's ma'am? You are muted. Yeah.
Imrana, you've gone mute. You have to unmute yourself.
It's not muted.
Sorry, am I audible now?
Yeah, now audible, now audible.
Okay, I'm so sorry. I'm so sorry. Where was I? So I was saying that, this 60s and 70s is a period of turmoil in larger macroeconomic planning, in which health is caught up. We change track and we go towards heavy industrialization by the state, whereas manufacturing is taken up by the private sector because the money comes quicker there, agriculture is neglected, and the welfare sector starts deteriorating. Not really deteriorating, but it is not progressing as fast as it could. That period has been criticized by many, and I'm not going to go into that debate. I know that this is what happened, and we have to move, and you can read the political economy of development in this country and decide for yourself. I will only tell you one thing, that during that period, we had only 4% growth, but the distribution of wealth was much, much better. Today, we have high growth rates. After 2005 onwards, we have very high growth rates. And we are still claiming, although it's very debatable, but this growth is called a jobless growth. This growth is not related with welfare. So this brings me to the phase of what is this structural adjustment and what has it done to us? Because, as I said, that the classical models of public health and even the Mahalanobis and Nehru's dream of linking up economy and public health was something very different. I believe, at least conceptually, it was ethical. It put people in the center and tried to handle poverty, which would be a means to tackle health problems and many other social sector developments. Now, whether we were wrong, not wrong, why it happened, these are questions that we must analyze and understand, but I am not going to talk about it. You will have to explore this area because I think it is very important to be able to believe in something. Now, very interestingly, if you look at the Bhore Committee, as I told you, it has a very beautiful objective of providing healthcare to all, irrespective of their paying capacity, and that the state is responsible for services. You can find faults with the recommendation that there was this problem, that problem, but basically this is the thrust. When I look at the 1983 policy document, it's very interesting. Even 1983 till 83, the policy is talking about building a comprehensive public health care system. Remember 1978, 1978 Alma-Ata had happened, and all we had done was to collect all the documents which were talking of different sectors. We put them together and we called that document Health by 2000. But despite that, the policy document continued to talk of comprehensive primary health care, of building an integrated service system with adequate referrals, and from tertiary care to primary care, up and down. There was only one thing. It said they will promote specialization and super specialization, and the rich may pay for it. And that is the beginning that I see of a very different trend. The 70s is a very interesting period because on one hand, there were all the pressure of World Bank and the debt that we had and the problems that we were having. And yet, we were trying to do many things, we tried the CHW scheme, we tried the ICDS in 1975. Community health worker was 1977. Then we tried reorientation of medical education in 77. Then, of course, Alma-Ata. And then 2005, NRHM came, but that's much later, not in the 70s. So, despite these efforts, they almost fizzled away. And once we accepted the policy of structural adjustment, what we had was acceptance. We had, in a way, we had political quiet in the country. There was, as feared in the 70s, when the working class was threatening, railways were threatening a major strike. And that was one of the reasons why emergency was launched. Also the fact that Mrs. Gandhi wanted to control the banks, and so she nationalized banks, controlling them from the penetration of private capital. So there were very interesting forces which did all that. Anyway, that period could not contain the pressures. And as we all know, the tragedies of emergency, and then the coming in of the Janta government. And the Janta government chose, instead of handling the problems in a better way, to go in for more and more debts. And under the debt pressure, we had to accept all reforms, including health sector reforms. And the first phase of reforms was actually, let me confess that today I'm talking like this. But in the 80s, I was very busy doing all those, learning about all those reforms and hoping that Alma Ata will succeed, that we'll be able to make good of the CHW scheme, that Rome may do something better and our doctors will be more sensitive and our links with the district hospital and the prime and the medical colleges will be better. So we were still thinking within the framework of the medical care and public health system in the restricted fashion. We were not looking at the larger macroeconomic processes. Now, the first set of reforms that came were opening up of the public sector through withdrawal of investments. So we went, you remember, we went to 0.9% investment in health center. And from there, then we gradually limped to 1 and 1.1 and 2 and came up to 2. And what is very interesting is that today the new budget is claiming a 2.1% investment, and the Lancet Commission is challenging that. And they are saying we have only 1.2% investment. Now, I'm not going into that. You can look up that debate and see why why the difference. But my point is 1.2 or 2. Yes, there is a marginal difference. But the important thing is that whatever is coming, how is it being invested? How is it being used? And that is what we need to understand when we look at the reforms. So the reforms not only withheld resources from the welfare sector, and especially health sector, they also introduced private insurances. And the private insurance in the first 10 years were really bad, not more than 5 to 6%. And even today, it's not more than 10% anywhere. We introduced also the public-private partnerships. The first corporate hospital was set up by Apollo in 1983. And 80s and 70s saw a very rapid rise in the growth of private hospitals. They began with nursing homes and they went into private limited hospitals. They registered as under the Companies Act, and gradually the corporate sector started growing, even though it was a very small proportion of the private sector hospitals. During the reforms, the health sector reforms talked of a social security net, that when you introduce reforms, you will ensure that a certain amount of social security is provided to support those who are going to carry the burden of reforms. this never happened. There were hardly any reforms, except for, I believe, NRHM. I think NRHM was an effort to, by Prime Minister Manmohan Singh, to ensure some basic services, even though it functioned as the means to break the referral system between the district hospitals and the higher institutions, be they medical colleges or research institutions, state level colleges, whatever. Because it was a district scheme. And that was the first disintegration that happened. Although I know that NRHM did some good, but NRHM never received the money that not only that it needed, but also that which it was promised. So it was always under provided. So this is over the 90s, and NRHM is in 2005. So the more active period is between 2000 to 2016 and 17. This is an interesting period because it is during this period that governments changed. Manmohan Singh government was trying to bring in the reforms and also trying to have some little welfare input. So they were playing with programs like NRHM. But post 2000, what we have is we have state-run insurance system, yet another model of public-private partnerships. In 2007, we had RSBY. This, the experience of state-run insurances taught us that there is too much variation, that there was a lot of corruption, that the center needed more control over what was happening. And so the state run insurances either stopped or continued to run in some of the states, and RSBY took over. Now this scheme, Rashtra Swasthya Bima, gave very little money, 30,000 for insurance, but the premium also was very low. So it really didn't, it may have helped some people, but it wasn't very popular. And after the shift in the government, it was converted into the PMJAY, that is the Prime Minister's Jan Swasthya Arogya Yojana. Now, I will take a minute and stop at PMJAY. So you see, on one hand, the public service system is not getting adequate resources. The supportive welfare is weakening. It's not reaching people. And then comes this scheme, PMJY, and it was called a flagship scheme. And the rationale was that the out-of-pocket expenditures are so high, and so is the need, because a lot of people are falling into poverty because of the excessive expenditures due to illnesses, serious illnesses, and therefore we need to support the poor to cover their expenses. And this scheme provided a 5 lakh insurance with 300 premium money. And it was said that 10 crore beneficiaries will be covered, and they will be the lower rung of society, economically backward. And for this, 65 billion, that is 6,500 crores were given. A huge money, and it was expected to cover the lower 40% of the population. Now, we did some calculation. Unfortunately, this is an old paper, and unfortunately, even today, we don't have the current NSS data. But even in the 1916-17 NSS data, what we did was that we took the entire sample and we calculated what is the size, how many people are getting hospitalized. And then we also calculated what is the cost of each hospitalization, an average cost of hospitalization. And what we found was that there were 18.5 million hospitalizations. And given over 16,000 rupees per hospitalization, we calculated that it needed 294.8 billion rupees and not 65 billion that the state had given. So this so-called flagship was also under budgeted. The interesting thing is that if you add to this figure the inflation, because it's an old figure, and the other expenses which go with hospitalization, then this amount of 294 goes to 358 billion rupees as requirement. So what I'm trying to say is that a huge problem of tertiary care was put forward, and as something that the state is doing, but the resources were inadequate. And if you look at the coverage provided by NRHM, all through its inception until today, the coverage has been very poor. As of 2023, according to the government, the number of cards made are very high. But what is interesting is that the actual hospitalization covered is very poor. So of the people, 10 crore people, families, 10 crore beneficiary families who were to be covered, not more than 40% were actually covered. And I'm not going into the qualitative aspect of it. There is enough work done to show the mismanagement, the inadequacy, and the corruption in PMJY. PMJY, as an insurance system, has failed, was proven by the pandemic. During COVID, according to the government's own records of the diagnosed cases who required hospitalization, which they count as 329,254. Only 9.6% were given admission under this scheme. So when in an emergency like COVID, this is the situation. In ordinary situations, you can imagine what was happening. Then PMJY does not cover OPD services. And PMJY is a part of a larger scheme, which is called the Ayushman Bharat scheme, which has also appropriated the primary healthcare system. As you all know, all this debate about what it's the primary health centers should be called temples of Swasth. So those temples were to be given 80,000 rupees to do comprehensive public health, which in addition to what PHCs were doing, were supposed to do all kinds of services, from yoga to health education to training to diabetes, hypertension, you name all the non-communicable diseases, they're all there. Now, you can imagine what it means. So I will stop at that. So as a part of this PMJY, it functioned as a tool to take subsidy from the state and give it to the private sector. And this is important to understand, because what is happening is that they are empaneling hospitals, and they say we are empaneling both public and private. The empaneling hospitals we have seen through the 80s and 90s that the public health system has been deprived of resources. So it is in a bad shape. It doesn't have resources. It doesn't have medicines. It doesn't have personnel. So when people have to register, and if they have to stand in long queues, if the doctor is not available, if the drug is not there, then they say, why should I register? I will go to a private hospital, which will give me these things. Then what happens? That the money comes on the basis of cases you register. So over time, what has happened is that the money to public hospitals has further shrunk, and the money to private sector has gone up. I think Indranil showed you the graph last time, that if you compare NRHM and this scheme of PMJY, you will see the vast difference between investments, the curve going up, although last 2 years it's not gone, the difference is not very high in its own curve. It's slightly lower, the rate of growth, but it's almost 6 times over. So this PMJY, PPP hospitals and corporate hospitals, medical tourism is yet another thing which is promoted. No worries about what is your epidemiological priority. You develop tertiary care for the incoming guests, and you earn and empty their pockets. That's the principle. And we are flourishing in medical tourism. It's not surprising that of the 69,000 hospitals today, and this is in 2023, 43,000 are private hospitals, and most of them are indulging in one or two of these PPP practices. Another thing that has happened as reforms over time is that, you see, it's very interesting that foreign domestic investments were low in the beginning. World Bank was particularly not interested in investing in health. But it is only after these changes that the banks have become very interested in getting into FDIs, and we are getting FDIs from different sources. And the government on our part, we are lowering the bars. So earlier, you could not put in more than 49%, because then if you have equal share, then the decision making alters and you get more rights. But today, FDI, we have 100% in institution building. So you see that a lot of foreign money is now coming into India to invest in the form of direct domestic investment through International Financing Corporation, which is the arm of the World Bank, equity funds, and also funds from multinational companies, obviously. I'm not going into the section on drugs, equipment, and devices, because that's a area of huge investments in FDI. So this entry obviously means that the control over the working of the hospitals is now changing. So they set the priorities, they set the choices in what services would be given, and what would be the price that the people are going to pay. So FDI, the role that it plays is in this, that it alters the working of the institutions, and then it connects with national policymakers and influences them through different means. Then they thought of producing corporate social responsibility. This is yet another means by which the state said it is trying to involve the private sector, the corporate sector, in doing good for the people. If you look at the list of CSRs, it's just ridiculous, because they are totally irrelevant schemes that they take on. Most of them are run by the family itself, and the CSR became a kind of tax saving device. Lately, the government has even tried to control and put them into given areas. But those given areas are then not what people need, but what the government needs. So today, if you apply for CSR, you will be given, these are the choices, you can work in this, this, this. So it has a double-edged, it has become a double-edged sword. Then obviously, given the fact that the tertiary care is being promoted, the whole effort of bringing in technology, and not just technology, but available technology. This is very interesting thing, you know, because if you are earlier, we used to talk of appropriate technology. We don't talk of appropriate technology now, but they are now doing promoting what they have. So the technologies that they have will be promoted, but it's not the technology that you need. So in 2016-17, these reforms were destabilizing the system, but the destabilization came from two other sources. Actually, three, but two are man-made. One was the GST in 2017, and the other was the demonetization. And it completely threw the economy, the peripheral economy of this country out of gear. The small businesses, the laborers, they were just thrown out of gear. And we know the walks back to the villages, and many of them never came back. Now, this destabilization encourages what? Cheap labor. Because when they come back, they have to work on conditions that have now altered. You have the labor laws. You have a different set of conditionalities. So when this happens, and you pushing technology, and after 2017-18, the technologies that they are pushing are very different. We are now pushing digitalization, be it in communication, data collection, data analysis, big data sales, telemedicine, self-monitoring. You know, you wear those watches and you keep saying, what is your heart rate? So digitalization, then innovation in pharmaceuticals and diagnostics, because we also offer cheap and innocent populations for experimentations. Then there's a lot of merger and acquisition happening within corporate and private limited hospitals, and that's the way to develop monopolies. And we have completely shifted from care, that is service, to coverage. And that's what the national health policy did for us, that we have now coverage. So you pay and you get your services. And we said that this will be only for the 40% of the poor will be covered. And I've already told you what is the state of that. Now they are talking of the middle level population, which also needs to be covered, and that needs to be covered through group insurance. So another kind of insurance is coming in, and you are required to get into group insurance. Now, then what are the implications of these kind of reforms? It's very clear that structurally, because of the depletion of resources, because of the altered conditions of the relationship with the private sector, where the public sector has no level playing field. It is definitely, it starts at a lower level and it continues to be deprived of resources. So there are shortages of manpower, material, shift of resources, of manpower shifts, diagnostics, casual, and there is a referral disconnect, there is fragmentation in the name of autonomy. And the district hospitals today are autonomous. And autonomy here means that you have to get your own funding. And if you have to get your own funding, then you have to provide services which are more paying. So the need-based planning processes have been given up. Then at the hospital level, at the micro-institutional level, it is the health manager who has power over physician autonomy. So it's not the patient's concern. That has shifted to profits. And today, efficiency is not efficiency in terms of coverage and cure. It is in terms of cure and profits. So the issue of coverage has been thrown out. Interestingly enough, many public hospitals are also now building private wards because they need to earn money, so they have developed private wards. And when they develop private wards, there is differential care. The patients in the ordinary general wards certainly don't get neither the doctor's attention nor the material attention that they need. A lot of work has been done on the shifts that have taken place within hospitals. And they range from the fact that diagnostics, ancillaries are all privatized. The quality has gone down. And not only that, when you put in, like Vijaya's work shows in Kolkata, when you put in the MRI, private MRI unit in a district hospital, and then the deal is that 200 patients will get it at subsidized rate and the rest has to pay. And the 200 is first come, first serve. So the rest of the patients are all the time dealing with that private unit. And that private unit is acting upon other doctors to write investigation of MRI for other patients. So all kinds of practices are emerging out of this restructuring. The doctor culture has changed because they're influenced by the corporate culture. They also want to make money and they don't have the earlier empathy. It's very interesting. We did a study of 3 cities in which we compared the public sector doctor with the private sector doctor. It's not that the private sector doctors did not have people who were concerned, who didn't think that we need a more equitous system, but everyone said, but that is the state responsibility. So they absolved themselves of the responsibility. The public sector doctor who's constantly working with the poor has a lot of empathy with the poor and he's very disheartened. And he just sees no options but to go with the flow because the hospitals are changing their shape. And then there are those who are very upset that their hospital is not being given private beds, that they are not being allowed to build private clinics, and so on. So the difference is quite interesting, and the shift in perception and culture. So when you look at these transformations, what is the thrust? The thrust of the reforms was that you shift subsidies from the public sector at the cost of the public health system and gave it to the private sector. Privatization to first commercialize, because you have now converted healthcare into a commodity, you are charging. And in this process of commercialization, when the private sector gets the national and the international come together and they begin to move to financialize. That is the most dangerous point, which I think we are now entering, that your commodity is now on the stock exchange. Its value is like any other money. And earlier, there was some concern about the production of service at the level of the hospital. Today, the interest is the production of profits. And that money which you are making out of profits is not going to be reinvested. It can be shifted anywhere in the world where you get higher returns. And that's called financialization. So from empathy and care to commercialization to commodity formation to financialization. And that's the route that we have taken. And this route has changed the concept of public health itself. Today, we don't understand the difference between public and private. We are told it's one system. I believe it's not one system. We can discuss about it. Because one is we are answerable and we have to be transparent in public sector. Whereas the private sector has no such compulsions. And public sector is supposed to respond to the needs and not just do that which is supposed to bring a lot of money. But you can see that the influence of private sector is such that the public institutions have started behaving like private sector. The second thing is that it is said that public health is no more a public good. Because earlier we understood public good as something which is contestable and non-exhaustible, non-contestable, non-exhaustible. That if a lot of people are using it, there is no conflict. And the material that you are using, the thing that you are using will never be exhausted. And that's true for a public hospital because doctors come and go, but the service continues. The change in definition was that contestable goods are those which can enter the market and therefore medical care can enter the market. Therefore, it is not contestable. Yes, if you are talking of environmental sanitation, nutrition, that can be public good. But medical care, where the money comes from, is no more public good. Similarly, as I said earlier, efficiency is redefined as low cost effectiveness minus coverage. CPH has been converted to UHC. Today, we just talk of UHC and we have forgotten about comprehensive private health. So these shifts have been introduced by a large number of global policy makers. And what I want to say is that we stopped planning with the formation of Niti Aayog in 2015. But the global policy people plan, and they plan to use medical care in our country as a means of making profits and gain those finances to then go back to the global market where they compete for finances, whereas they keep the third world countries out of the global market. Now, I want to stop here. What I'm trying to say is that everybody blames the public sector, that it's of poor quality, that it doesn't work, that we have to wait a lot. But we have to understand why it has become like this. When till 70s, there was so much life in this system. These are some of the reasons, I believe, which has brought us where we are. And therefore, the question is, what are we to do? And I believe that, we have to work wherever we are. If you are an institution, you have to work for the centrality of the patient and for your own right of autonomy, wherein your clinical decisions are respected and not undermined by the primacy of profits. If you are working in a primary health center, then you know how much you can do or what you can't do. You have to find challenges at each level, work against them, link with each other, link with people outside who are working on health, like that day. There was a talk on movements and public health movement and health movement in India, the Rajasthan experience. So we not only link up with health movements, but I think we need to link up also with political movements, with civil society movements. Of that, there are many. And it is only this function, I think, that MFC needs to promote. But to do that, we have to understand the complexity of public health system. Thank you, Tracy. Sorry I took so much time. I'm very sorry.
Thank you so much for the very insightful presentation, ma'am. So it was like, you have taken us to the lakes of history and shown us the evolving relationships and then how from pre-independent in colonial period to until today, how it has evolved through. And what is the shape of public health system today with the huge burgeoning private sector and who is benefiting it more? So again, thank you so much. And the floor is open for discussion. And please raise your hands and start.
Please let me tell you one thing.
Okay.
Just one thing. See, what I'm presenting is a very broad framework, okay? I have not filled in any details. I have not given you any data. So actually, we now need to fill in. And therefore, it's not a question answer session. I mean, I would like people to tell me if they disagree on something. And if they agree, then why? And I think it will be very interesting if we see that in all these areas, how states differ. You see, what I'm saying is a very general thing. Now, Kerala is very different from UP. And so the different experiences from different states. That's one thing. And the other thing that I forgot to mention, for this presentation, I was trying to look up Kerala. And I found this very interesting experiment of what they call the Fair Care organization. Now, what do they call it? It's a Fair Care network. It's a network of a small providers. It's a network which connects, so they They do their procurements together. They do their linking up in taking care of the patient. So if he goes from one place to another, his data can be shared. And they are trying to develop a kind of cooperative working. Now, I thought that that was really, really interesting because you see, the private sector is doing the same thing. The metropolitan cities are now full of this, pastry serving, well lighted hospitals. Now, how many can you open? So, what they're doing now, one they did was building the chain, and the chains are Apollo and Fortis and what have you, all of them all over. Then the second thing they did was that they started spreading laterally. You build a small clinics and you call it primary health centers. We have it in Delhi. Apollo has primary health centers all over. And their purpose is that they work as clinics and they catch cases which need tertiary care and they take them to their hospitals. And similarly, I think Netralaya has this, that they are opening small units in the smaller cities. So the private sector is also now penetrating the smaller cities. It is penetrating primary care. And we have no alternative. So I found this Kerala experiment very interesting. And I would like to really hear more about it. And I have not talked of the social determinants part of it. And I'm not going to talk because let us just tackle this. I think there's enough to debate.
Yes. There is one question from Raja. As a visionary, what do you think about the future of public sector and primary health care? Is there any future?
Because till there is need, there will be a way for primary care. Maybe we will not give it. Maybe your system will not get it, but people will devise something. I have great faith that we are not the only people who are disturbed and thinking. I think common people also think and they make choices. You go to the slum areas, you go to the villages. Why is it that, as Indranil presented that day, hospital visits are declining? Why is it? You think people are not falling sick? There are only two options. Either they are decided to die. Why waste the money? I have to die. Let this money be used for my children. Or they have an alternative. And I think that alternative will emerge. It may emerge in different forms. It will emerge from people's movements. It may emerge in alternative medicines. It may emerge in people using the untrained practitioner. Mind you, I know you will all be very angry with me, but I believe that those who are not taken care by our system are being held by the untrained practitioner. I have seen in the city of Delhi that the worker who comes out of a factory and he has a big gash, he needs a dressing done. If he goes to the MBBS doctor, he will charge 500 rupees to use the same cleaning solution, whether it is iodine or whatever, to put the same cream and bandage. He goes to this man, he takes 50 rupees and he does the same. The entire IMA and the system is trying to stop their practice because they are considered dangerous. Now, we are not helping them. If they are going to somebody, why are we stopping that person? They are taking the risk. So, what I'm saying is, people always take the risk. Either they take the risk of finding an alternative or they take the risk of beating us up. That's my answer to your question.
Jaykrishnan, please go ahead. He has raised his hand. Jaykrishnan? Okay, then I'll read a comment. Lovely from Geeta Govindaraj. Lovely, vibrant, and insightful talk. Pardon? Are you speaking, Jaykrishnan? Okay, then I'll read. Geeta Govindaraj, lovely, vibrant, and insightful talk. I think that the doctors in public hospital need to have faith in their ability and the value of the work they are doing.
Yes. I completely agree.
Yeah.
There are excellent doctors in both sectors, believe me, but it's not a question of individuals. It's the question is how we get together to find ways to meet the challenge.
I think everyone is still in the magic of your talk, you're just thinking and
No, there's no magic.
the sense.
No one knows about this scheme that I'm talking of. There's a
Yeah.
paper which is
Hello,
called.
madam. Can
there-
you hear me? Jagadishan
Oh,
here, madam.
Oh, hello, Jagdishan. Yes, of course,
But
I
I'm not
can
in a
hear
very
you.
comfortable position. I don't know whether you can hear me. I'm not
No, I
informed.
can hear you very well.
Okay, madam. I don't know whether you were talking about that Ardhram mission since 2016 in Kerala. We had a comprehensive primary healthcare project, and of which we were all part. And
Adharam, that is
very good.
Adharam.
Yeah, that
No,
was
this
Ardhram mission,
is
and
not
that
government.
Yeah.
This is what I'm talking of is not the government sector.
Okay.
It's the small providers in Kerala. And right
private sector.
now,
The private sector.
yes.
Yeah.
So why not? Why don't
Yeah,
we
sure.
join hands with them
Yeah,
if they're doing good work? And we should find
Yeah.
out more about them.
Agree, madam. Since 1970s, we've had very good private sector, small hospitals, and including missionary hospitals. And now we have
Yes,
funded
sure.
a phase in which, as you rightly pointed out, these corporate hospitals, they started their clinics at everywhere, and more private small hospitals are getting accommodated by this. They just incorporated into the corporate or private hospitals. That is happening.
Absolutely. They are eating up. It's the large fish eating the small fish. The small fish has to come together.
And
I
those
think
private hospitals, the rates were very, very less, and there was to some extent some sort of a family care even was being provided. That personal contact, everything was there. And madam, I agree with that, madam. Another dimension which I try to bring into your discussions, it was your session was reminding us very much our sessions of 1990s, such CSMCH, madam.
See,
so
we
thank
are
you
still
so much.
there, Jagdishan. We don't move.
The point which I try to bring in is that since Kerala is also facing that last 10 years, so in addition to whatever policy changes, economic changes, the global involvement and all, the way the government of India is behaving to state governments for last 10, 12 years is something different, which we were not facing earlier. since those governments who are in opposition run by opposition parties, they are not just giving the money. The deserving state share is not getting. So, or they have to keep fully online with whatever they are saying, like issues like branding the healthcare institution with somebody's logos, photos, and also that way all the opposition parties governments, including Kerala, Tamil Nadu, West Bengal, and all are facing. At some points, it is a mere crisis of money, and even find it difficult to pay the NRHM staff their monthly salaries. So that way, never before this way, the politically this central government's money and this even this money is collected, as rightly pointed out, through the GST and all, which state is very much deserving, and that again it's entering in such a new phase, and in which for the political mileage they have been using it by this central government, and that dimension also I would like to just bring into your discussion.
Jagdishan, I mentioned demonetization and the GST laws. And the very purpose of GST is to weaken federalism and to increase central control. The amount of money they are extracting out of people, God knows when and where it will stop. But I completely agree with you. It's happening all over. The states are being harassed, controlled. I mean, look at what is happening in Delhi, look at what's happening in Kerala, look at what is happening in West Bengal. Everywhere it's the same story. If you are not in their platter. So that's why I feel that we as doctors and as concerned people cannot just stay within the boundaries of medical care and health care. How long? You won't get salaries, and what will you do? So you have to join in with other movements. You have to join in and see what trade unions are doing, what health movements are doing, what civil society movements are doing. We have to learn more about how this system works and how they're able to control us. We simply don't come together. We don't talk of larger issues, and we keep trying to do medical care and technology. And we have to get out of that. I mean, you continue doing that. Don't get out of it. You continue doing that. You fight for a better technological answer, and also connect with others.
Thank you, madam.
No, thank yous.
Madam, I have a comment to make. I'm Dr. Krishna Kumar. Actually, your observation that the small hospitals are disappearing, it's a glaring fact in Kerala. In small villages, small towns, and small hospitals run by individual doctors. They're contributing significantly to the health of the society, and they're all disappearing now, taken over by corporate hospitals. And the other thing is, when we were doing MBBS and all, after MBBS, many people used to start their own small nursing homes, do private practice, and that thing has disappeared now. After MBBS, they directly go for PG, for entrance, NEET, and all. And also, there is a doubt. Actually, we had a discussion on the competency of medical graduate after finishing.
And that too from private medical college.
Both private and medical colleges. That also is a point to discuss, man.
Absolutely, absolutely. I had it in my notes, but I didn't take it on because there's just too much to discuss. And you are right, because even in MFC, I think we once had a discussion about the problems the young doctors are facing, because they cannot compete in the market anymore. They cannot sit there unless and until they agree to give cuts. So they will send you a patient and you have to give a cut. So they can't. So they have to go to post-graduation. They have to. So there is a kind of social trajectory that is being laid out for them. And they are forced to join the corporate hospitals at very cheap rates. The corporate hospital personnel, the star is the consultant. He comes and goes to 10 hospitals and he collects his money. He is not responsible for any hospital. It's the juniors who are responsible for the hospital. But the juniors work under very poor conditions. The nurses are worse off. And class 3 employees, I don't even want to talk to them. Their pays are written something and they are given something. That's the state of corporate hospitals. I can't. Tracia, you are not audible to me.
Okay.
Better. Yes.
There is a comment from Mohan Mulakal. A very good presentation touching both upstream problems and downstream anxieties, making doctors and people to think about a big challenge ahead to overcome. And Shaima has shared, please share the paper you were talking about earlier on the Kerala experiment on primary healthcare. Could you hear, ma'am?
Yeah. Experiment on primary health care or the safe care network?
Maybe the same.
Yeah,
she might have thought that.
Okay, I will. It's not primary health care. They are just providing services which are humane, which are patient oriented, which are accessible, and they connect with each other. They support each other and they help each other. And I think it's a very good idea. So I will certainly send. Okay.
I think it's anybody else. I was just looking, someone wants to say something to you or to the group or so again, ma'am, thank you so much. And it was a visual treat. And then it's like, we were very nostalgic about your classes, and then somehow I was like into it. And next week, next week, I think next Thursday, as I said earlier, we all meet in Calicut. Hope we all will meet. It's a sad situation for Kerala, and it's a bit, what shall I say? I mean, energy level has gone down, after the
I can imagine that. I can imagine all the pleasure of meeting and that warm thing. That I can imagine. It must be very depressing.
Yeah, that's otherwise I think we all will meet and we'll have discussions for long, and we'll again meet online also now. So after that, we'll decide whether how to continue these online sessions. Maybe next Thursday, and one more Thursday we will take off, and then we will continue our discussion in the same way or in a slightly different mode. Thank you so much.
I think you have to have a more interactive session. I think you have to have and a follow-up, like if you had these sessions, now you follow up on them. Who said what and how do you take it forward? Thank you so much. Thank you for having me. And it's lovely seeing all of you.
Bye-bye.
Whoever bothered. Bye-bye.
Good night. Oh, somebody has written something. Let me just see. Please share. Thank you, Aarti.
Aarti, where is she? I don't see her. Anyway.
In fact, she was supposed to.
Thank you for being here. Hi. So lovely to see you. Okay,
Bye.
till
Good
next
night.
time.
Night.
Bye bye.